Welcome to our video on pulmonary hypertension. Let's begin. For pulmonary hypertension, we'll discuss its definition, pathophysiology, clinical presentation, diagnosis, and management. Pulmonary hypertension is defined as a mean pulmonary artery pressure more than 25 at rest. Pulmonary hypertension can be caused by various mechanisms. There may be passive congestion of pulmonary vessels by blood from the left side of the heart. This can happen in left-sided heart failure where we have a backup of blood and pressure in the pulmonary vein. Passive congestion of pulmonary vasculature can also occur in the setting of a mitral stenosis or a left atrial myxoma. Additionally, increased pulmonary blood flow through left to right cardiac shunts can increase the pulmonary mean arterial pressure. In this case, there is simply a greater than normal amount of blood filling up the pulmonary vessels. Examples of this mechanism include ventricular septal defects, atrial septal defects, and a patent ductus arteriosus. Pulmonary hypertension can also be caused by a small subclinical pulmonary emboli. These emboli lodge into the small pulmonary arterioles and then get reorganized. In other words, a new, although narrow, vascular lumen is made in the center of the embolus. This narrow lumen leads to an increase in pulmonary vascular pressure. Vascular obliteration is another cause of pulmonary hypertension. This usually happens in connective tissue diseases such as rheumatoid arthritis and systemic lupus erythematosus. Finally, lung diseases causing persistent hypoxia can induce hypoxic pulmonary vasoconstriction, resulting in pulmonary hypertension. Such conditions include chronic obstructive pulmonary disease, obstructive sleep apnea, and diffuse parenchymal lung disease, to name a few. Let's move on to clinical presentation. Pulmonary hypertension commonly presents with dyspnea on exertion and fatigue. It might also be accompanied by exertional chest pain. On physical exam, a loud P2 heart sound is detected due to high pulmonary vascular pressure. A parasternal heave felt to the left of the lower sternum is caused by concentric right ventricular hypertrophy due to increased right ventricular afterload. Right ventricular hypertrophy can also cause right-sided heart failure. Heart failure in turn will manifest with jugular venous distension, ascites, hepatomegaly, and peripheral edema due to a backup of blood in the systemic veins. Here's an image showing jugular venous distension that may be present in pulmonary hypertension due to right-sided heart failure. Note the rope-like distended vein present here on the side of the neck. This image shows pedal edema, which can also occur in patients with pulmonary hypertension. Note that the edema here is pitting, meaning that it takes time for the imprint of your finger to disappear after pushing on the patient's leg. Remember that pitting edema is not exclusively seen in pulmonary hypertension and can be indicative of other disease states as well. A 47-year-old man comes to the physician due to worsening dyspnea on exertion. He was diagnosed with idiopathic pulmonary fibrosis 10 years ago. Physical exam reveals hepatomegaly, ascites, and lower extremity edema. Chest x-ray shows enhanced pulmonary vascular markings, what will most likely be found on the cardiac examination of this patient. This patient has worsening dyspnea on exertion, hepatomegaly, ascites, and lower extremity edema. All these findings suggest right-sided heart failure. Considering that he has had idiopathic pulmonary fibrosis for 10 years, he likely has pulmonary hypertension secondary to pulmonary fibrosis. Cardiac examination in patients with pulmonary hypertension will typically reveal a loud P2 component of the S2 heart sound and left parasternal heave due to concentric right ventricular hypertrophy. Let's talk about the diagnosis of pulmonary hypertension. Electrocardiography of a patient with pulmonary hypertension will show right axis deviation due to right ventricular hypertrophy and P pulmonale, which is a peaked P wave due to the right atrial dilation. The right atrium becomes dilated in pulmonary hypertension due to backup of blood from the right ventricle to the right atrium. Chest x-ray, on the other hand, will reveal enlarged pulmonary arteries. Echocardiography will show a dilated right atrium and ventricle, right ventricular hypertrophy, and enlarged pulmonary arteries. Here we have an EKG showing right axis deviation and P pulmonale. Please note the QRS complex is negative in lead 1, positive in lead AVF, indicating right axis deviation. P pulmonale are these peaked P waves caused by right atrial dilation. This is a chest x-ray of a patient with pulmonary hypertension. Please note the enlarged pulmonary arteries. Here we have an echocardiography of the patient with pulmonary hypertension. I would like to draw your attention to the dilated right atrium and right ventricle. Here is a CT scan showing a dilated pulmonary artery marked by a red arrow, which suggests pulmonary hypertension. Additionally, there is ballooning of alveoli marked by the blue arrow, suggestive of emphysema. Recall that obstructive lung diseases such as emphysema can be associated with pulmonary hypertension. Finally, right heart catheterization can be performed for the definitive diagnosis of pulmonary hypertension. However, it is not routinely done because it is an invasive procedure. Right heart catheterization will show a mean pulmonary artery pressure greater than 25. Here's an image showing how right heart catheterization is performed. Appreciate the fact that Swan-Ganz catheter is first passed to the right heart and finally to the pulmonary arteries to measure the pressure in these structures. Let's move on to the management of pulmonary hypertension. First, the underlying disease should always be addressed and treated when possible. General management is focused on symptomatic relief and includes home oxygen therapy and diuretics. Lung transplant can be performed in refractory cases. There are several medications that can be used for pulmonary hypertension. These medications dilate the pulmonary vessels and decrease pulmonary vascular resistance. Right heart catheterization with a trial of dilators should be performed before the onset of these medications. These drugs include phosphodiesterase 5 inhibitors such as sildenafil, tadalafil, and evanafil. Phosphodiesterase 5 normally breaks down cyclic GMP, a second messenger responsible for vasodilation. Inhibition of phosphodiesterase 5 will maintain high levels of cGMP that will induce vasodilation. We can also use endothelin receptor antagonists for pulmonary hypertension. A classic example is the drug bosentan. Endothelin normally causes vasoconstriction. Blockade of the action of endothelin will therefore result in vasodilation. Finally, prostacyclin analogs can also be used. These drugs include epoprostenol, iloprost, treprostinil. Prostacyclin and its analogs cause vasodilation. A 26-year-old woman comes to the physician due to fatigue and dyspnea on exertion. Physical exam reveals hepatomegaly, jugular venous distension, and bilateral lower extremity edema. Her cousin had the same symptoms at the age of 30. Chest X-ray reveals enlarged pulmonary arteries. What will most likely establish the definitive diagnosis in this patient? This young woman has dyspnea on exertion, hepatomegaly, jugular venous distension, and bilateral lower extremity edema. Given that her chest X-ray reveals enlarged pulmonary arteries, and her cousin had the same symptoms at an early age, all these findings are consistent with inherited pulmonary hypertension and concomitant right-sided heart failure. The procedure that establishes the definitive diagnosis of pulmonary hypertension is right heart catheterization. However, it's worth noting that right heart catheterization is not routinely performed because it is an invasive procedure. A 62-year-old male presents with significant dyspnea after mowing the lawn. His medical history is significant for COPD and diabetes. On physical exam, the patient's chest has an increased anterior-posterior diameter. He also has a loud P2 heart sound on auscultation. Chest X-ray shows enlargement of the pulmonary arteries and flattening of the diaphragm bilaterally. A right heart catheterization shows a pulmonary artery pressure of 32. What is the pathophysiology behind this patient's current presentation? A. Pulmonary blockage. B. Pulmonary vasoconstriction. C. Tricuspid stenosis. Or D. Decreased renal perfusion. This man presents with exertional dyspnea. He has COPD, which is confirmed with the increased anterior-posterior diameter and flattened diaphragm on chest X-ray. Additionally, he has a loud P2 heart sound, enlargement of the pulmonary arteries, and a pulmonary artery pressure of 32. Based on this patient's presentation and history of COPD, he is experiencing pulmonary hypertension, which is diagnosed with a right heart catheterization showing a pulmonary artery pressure over 25. Pulmonary hypertension in COPD patients is due to alveolar damage, which leads to a ventilation-perfusion mismatch and subsequent pulmonary artery vasoconstriction. Therefore, answer choice B is correct. Answer choice A is incorrect because a pulmonary blockage, as in pulmonary embolism, typically leads to acute and more significant symptoms which are not only present on exertion. Answer choice C is incorrect because tricuspid stenosis would lead to a backup of blood into the periphery and a decreased pulmonary artery pressure. Answer choice D is incorrect because decreased renal perfusion would lead to systemic vasoconstriction and hypertension, not only pulmonary hypertension. And that concludes this section.